Thanks a lot, James. So I'm going to put some of the NWAS findings in context, just to tell you about some of the research in the wider field on this, and then just briefly touch on my view of next steps at the end, which we can build on a little more in the panel discussion that we'll use to close this session. Just for transparency, my declarations, I do a lot of work with industry. All remuneration goes to my employer if there is any. So for context, we've made huge progress in hospitals with rapid diagnosis of acute myocardial infarction, thanks to high sensitivity troponin assays. So we can now tell people, based on a single test when they come to the emergency department, that they haven't had a myocardial infarction in a significant proportion of cases, either because just using the high sensitivity troponin test, if they've got a really low level on arrival, it's very unlikely that that's a myocardial infarction, and immediately you can rule out that diagnosis. By bringing in other information from the patient's history, examination, ECG, as well as the troponin, even more patients could be told after just one test that it's not a myocardial infarction, and they could be reassured. And for the remaining patients, we do the second test just an hour later. And by that time, the vast majority of patients are either ruled in, they've had a myocardial infarction and we know it, or ruled out and we can safely go home. So that's revolutionized our hospital care. But the advent of point of care tests that are portable means that we've now got the potential to move that to the pre-hospital environment and get the benefits before the patients even arrive in the hospital. It's not really doing something totally new. It's moving what we already do, as James, I think, articulated in the first presentation earlier. So we're doing it before the patients arrive in the hospital, cutting out waits and allowing early reassurance, hopefully, for patients. So it's been articulated already that this is a massive problem. 1,500 EMS calls a day across England for chest pain. And if the paramedics suspect a heart attack, 96% of the time they'll be conveyed to hospital at the moment. And yet, 9 out of 10 of them won't have a myocardial infarction in the end. So if we could be telling those people, or a lot of those people, it's not a heart attack, and cutting out that journey, wouldn't it be better for them? Wouldn't it be better for ambulances too? They cut out the journey to hospital and the handover, which takes an average of about 45 minutes at the hospital. So ambulances get back on the road quicker, and hospitals are freed up so you have less crowding. We also know that ambulances are struggling for response times. The median response time for category 2 calls, which include heart attacks and strokes, was 47 minutes in December 2024, and the 90th percentile went up to 1 hour 41. So people with heart attacks having to wait a huge amount of time, and that's going to affect patient outcomes. So if we can turn around the ambulances quicker, then we can get the people who actually do have heart attacks and strokes responded to earlier. So James outlined the pathways earlier, but just to recap on what we see as a potential in the ambulance service, that patients would call for an ambulance, the ambulance would respond, and instead of just doing the ECG and a clinical assessment, we'll now add in this point of care troponin risk assessment with a Tmax decision aid to risk stratify, as Rhiannon pointed out. And then the high-risk patients would go direct to a heart attack centre. Moderate risk would be seen in emergency departments as usual. Low risk bypass straight to same day emergency care, and very low risk not conveyed at all. So just to illustrate the sorts of patients that we might be affecting the care pathway for, this is a typical case. I've made this up, but we see this time and time again. Typical example, 40-year-old woman who's recently had a family bereavement, who developed some central chest tightness. It lasted for 15 minutes. Everyone's very scared. They call for an ambulance, but then it resolves by itself. She's got no past history. Her partner's called the ambulance, but by the time it arrives, she's feeling back to normal. The ECG is normal, the vital signs are normal. She looks fine. But everyone's going to be a bit worried. It was a heart attack. So our current care pathway would mean she has to go to hospital. She has to wait in the emergency department for all of the tests, when most of the time she's going to be all right. She's not had a heart attack. She's got something else that's caused it. It might be dyspepsia. It might be muscular pain, but it's not likely to be a heart attack. So we could tell her that at the scene. Wouldn't it be better for everybody? So we did some work on this. We managed to get funding from the NIHR to do some work to look at the potential to use point of care testing in general in ambulances. And the first thing was to see what would be the highest priority for stakeholders like paramedics, patients in the public, lab medicine professionals, emergency medicine professionals. So we had a look at all of the options. What point of care tests are currently manufactured by industry that could potentially be deployed in ambulances? We did a scoping review. So these were some of the ones that we looked at. There were more than this. It's just a selection. Troponin, there's lactate for diagnosing infection, or lactate for looking at major trauma, looking at BNP for heart failure, or ketones for diagnosing diabetic ketoacidosis. There were some of the things that were found to be have a lot of potential. We developed a scoring system through 2 surveys and 2 workshops to essentially prioritise which of these the stakeholders felt would be most important to look at. And troponin scored consistently the highest of all of these point of care tests. The others were important too, because there's potential in other areas, but troponin was people's most important priority for ambulances. Then we interviewed the stakeholders. This was more interviews. Rhiannon told us about the paramedic and patient interviews, but we did some before that as well to look at the potential for this technology. And the paramedics and patients in the public we interviewed told us a lot of important stuff. There were some caveats to using it, but there was a lot of support for it. So with right treatment, the right time, the right place, and more quickly, talking about this being the missing link, taking us to a new generation of ambulance services, but noting that there are some challenges to overcome, like it's got to be really easy to use in a challenging environment, and we've got to have managerial support because there's going to be a lot of risk aversion, and so we're not going to get the benefits unless everyone's happy. So then we moved on and did some research to look at the accuracy. So we did something called the Presto study. So this was not our implementation project in NMS. This is just research. So all the patients were taken to hospital. They all had the test in hospital, but we drew blood in the ambulance to see how accurate the tests would be. So we recruited 817 patients across 4 ambulance trusts, and we had a look at the point of care troponin tests with 2 risk scores, the heart score, which is widely used across the world, and Tmax, which we use in Greater Manchester. And what we found, if we just focus on the right, Tmax came out on top. The sensitivity for a myocardial infarction is over 98%. So that means that only 1.7% of MIs will be missed by this point of care test. That's about the same as a lab test in the emergency department. And about a quarter of patients could have been left at the scene if we'd have used that in practice. Now, to do this study originally, we've used a troponin test that isn't high sensitivity. It's an old test. It's no way near as good as the lab technology that we're currently using in hospitals. And we went on to have a look at what would happen if we use the new high sensitivity tests subsequently. In the meantime, there was a study in Scotland called Access, which did the same thing, but with 1,000 patients, and they found pretty much the same thing. Heart score wasn't quite picking up all the myocardial infarctions, but Tmax was. In fact, none of the myocardial infarctions were missed, and a fifth of the patients could have stayed at the scene. So it gives us more assurance that this is accurate in ambulances. Then we've got some data from international studies. So in the Netherlands, they did something called famous triage. So they started off getting basic confidence in this in phase 1. And then in phase 2, they had usual care. Everyone was conveyed to hospital and just got lab tests in the hospital. And in phase 3, they looked at what happened after they implemented point of care troponin testing in ambulances. And you can see this is the incidence of major adverse cardiac events at follow-up at 30 days, before implementation and after. Now, the worry is if you start to use this and not take people to hospital when they're low risk, then you might get more events. You got less events in this. Were they more likely to be diagnosed with an acute coronary syndrome or heart attack in hospital? No. Were they more, in all of the patients, not just the low-risk ones, were they more likely to be more major adverse cardiac events? No. So it was safe, basically, is what they were saying. They implemented it and it was safe. And then in the Netherlands, again, they did a randomized controlled trial. So this time, they got patients randomly allocated to either normal care, go to hospital and have your tests, or have a point of care test and a heart score in the ambulance. And if you're low risk, you stay at home. And they looked at healthcare costs as their main outcome, but they also looked at safety outcomes, major adverse cardiac events. And they showed, first of all, no difference in the incidence of major adverse cardiac events. Now, there were wide confidence intervals around this, so it's not definitive. We still need a bigger trial, but it's a really good signal that we're not getting any worse safety outcomes when we use this in practice. And they found that they reduced healthcare costs by €611 per patient when you use a point of care test to leave some people at the scene. So, last thing I want to tell you about with the research that's been done is our second analysis from Presto. So the first analysis I told you about used that old troponin assay that wasn't high sensitivity, and things worked well. Now there's a new high sensitivity assay we could use, the ISTAT. So there's more than one high sensitivity assay. We were able to evaluate the ISTAT assay in ambulances in the Presto study. So it was the same study, 4 ambulance trusts, everyone has blood drawn in the ambulance, and then they're taken to hospital for tests, and we look at how accurate the point of care test was compared to the lab tests. And we got very similar results. Tmax, again, 98.9% sensitive, so a bit more than before, and a fifth of people could stay at the scene. So it's given us more confidence this works. One of the important things that came out of this, though, is just using the troponin test by itself. You don't even need Tmax. With a very low level of troponin and nothing else, we managed to identify over 40% of patients that's potentially not needing transfer. That would be incredible. The cost savings with that would be even greater than we projected in the NWAS project, if that stands up. So before I conclude, I just wanted to talk about those next steps. So that case, we can see in the future that potentially this patient could have a point of care troponin test and be left at the scene. What would we need to do in order to be able to do that safely? We've shown feasibility. We've worked through the processes in this pilot. I think that for people to be confident leaving people at the scene, we need a randomized controlled trial. So we've applied for funding for that, where we do what they did in the Netherlands. We'd randomly allocate people to point of care test or go to hospital for lab tests. But we'd have more participants, so we'd power it to make sure that there's absolutely no increase in safety events. And we'd look at the healthcare costs, and when we actually use this in practice. There's more than not just the modelling. At the moment, we're projecting what is likely to happen. In the trial, we'll see what did happen once we used it. That would give us the confidence to deploy it. But my feeling is that we could use this now for the rest of the patients. For high-risk patients, the troponin test clearly could identify the ones with a heart attack who could go to a heart attack centre, cut out secondary conveyance. For the other patients, arriving at the emergency department with a troponin result would allow us to get early risk stratification, make use of an ambulatory care environment straight from triage, hopefully speed up the ambulance handover. What we've seen is likely, if we deploy these tests on all ambulances, that it would increase costs for the ambulance trusts. So who's going to fund that? That's what we would need. We need commissioners to help us out to achieve the system-wide cost savings and benefits for patients. The ambulance trusts are going to need some financial support to recover those early costs. So in conclusion, we've got a rapidly growing evidence base for point of care troponin testing in ambulances, not just our pilot, but a whole lot else too. We do need some more evidence for the safety of non-conveyance, but there really is a potential to usher in a new paradigm for pre-hospital care through this technology. Thank you.